this drawing, nerve cells here set up in the brain or at the different levels inside the spinal cord or even outside the spinal cord in the periphery, ganglions here. And the neuron is another word for nerve cells. So note that in this cartoon, the size of the spinal cord and the neurons are greatly exaggerated in comparison to the brain. A thin line comes from each nerve cell, stretches from some distance in the spinal cord, then branches at its end to encounter another nerve cell. And these lines symbolize the axons, which connect each nerve cell to its targets. And in this case, the neurons in the spinal cord. And the spinal cord is primarily composed of bundles of axons. And axons function much like electrical wires. So, with the information encoded in bursts of electrical current, and the spinal cord axons carry orders from the brain to the periphery, such as along these pathways. And the body periphery send information also back to the brain, also through the spinal cord, as you can see here. And the axons in the spinal cord are essential for the brain to orchestrate our movements and thereby our lives. And the spinal cord is embedded inside the bony vertebrae for protection. Nevertheless, its slender anatomical structure makes it vulnerable to traumatic injury. And this patient here has a fracture with posterior displacement. And in this T2 weighted MRI image here, you can see the vertebrae. The spinal cord appears white, and the severe injury here at the red arrow, essentially a break in the cord. And this will disrupt the long axons that connect the brain and the periphery and leave the patient unable to feel sensations such as heat or pain and unable to move and affecting a great part of the body below the lesion site. And the major causes of spinal cord injury are traffic accidents, falls, and gunshot wounds. And apart from ruining patient quality of life, spinal cord injuries also impose extraordinary financial burdens on patients and their families. And just to show you some numbers, a patient who suffers an injury at the lower neck level, here listed as a low tetraplegia, losing control of both legs and arms, and typically incurred $770,000 in medical and rehab bills in the first year, and close to $3.5 million over his or her lifetime. And the high tetraplegia means injuries that affect not only the sensation and the motility, but also the ability to breathe. And these patients are, of course, the most severely handicapped. And the paraplegia is the kind of spinal cord injury that leaves you in wheelchair, but you can still use your hands and arms in some extent. And these numbers are direct costs and do not include the indirect, such as lost wages. So while broken skin or bones can heal, broken spinal cord axons cannot regrow. And therefore, spinal cord injury patients are often left with a permanent lack of sensation and paralysis. Why is it that spinal cord axons cannot grow and regenerate after injury? So on the first thought, this is baffling because all axons grow rapidly during fetal and juvenile development to assemble the neural network. And axons in the peripheral nerves in the arm and the leg can regenerate to some extent after injury, but not in the spinal cord. Now we know that is for two main reasons. The first In the mature central nervous system, nerve cells have a very low ability to grow their axons. Mature neurons in the central nervous system do not express the molecules that drive axon growth in the fetus and are unable to increase their expression after an injury. And in contrast, injury to a peripheral nerve triggers expression of these molecules in mature peripheral neurons. And there is this is a very, very important difference between central and the peripheral neurons, and has inspired a lot of research aiming to induce the expression of growth and regeneration associated genes in the adult central neurons. And the second reason is that in the spinal cord, axons are surrounded by supportive cells called oligodendrocytes. And these cells produce molecules that actively inhibit axon growth. And this makes sense in the intact nervous system because you would want working circuitry to be stable, not growing or changing. But in the case of the injury, these stabilizing mechanisms become counterproductive. And finally, the injury triggers the formation of scar tissue, and which physically block the axon extension. To reconnect severed spinal cord nerves, we need to remove the scleral scar or reroute axons around the skull barriers.
And you just need this done.
Okay, so my lab has been focusing on identification of signaling molecules that give growth in the young developing neurons and on the ways to activate these molecules to facilitate growth of injured mature spinal projection neurons. And this is our overall hypothesis. And the reactivation of the growth mechanism that are active in the fetus may reprogram the adult spinal projection neurons to enable axon regeneration after spinal cord injury. And what exactly makes axons growth in young neurons? So again, we go back to the literature. It has been known for over 60 years now that a small molecule called nerve growth factor, NGF, triggers robust axon growth from the embryonic sensory neurons, as you can see here in this dorsal root ganglion here. This is a before NGF treatment. And here's the after treatment. So now, what exactly does NGF does to these neurons to drive this strong axon elongation? So this schematic symbolizes the inside of the neurons, and this line is the cell membrane. So NGF here in orange docks to a receptor molecule on the surface of the neuron, and this receptor binding activates multiple signaling molecules in the cell. And here you see a few of them. The PI3K, AKT, BRAF, and CRAF. Those are names of these signaling molecules. So we ask, which of these molecules drive the axon growth? So in a petri dish, and when we activate PI3K and AKT in DRG neurons without NGF, axon elongation remains unaffected compared to the control neurons, as you can see here. So in contrast, activation of the BRAF protein by itself could completely mimic the axon growth effect of the NGF. Here you can see the very long axons. And having discovered the axon growth promoting power of the BRAF in the peripheral nerve cells and axons, and we looked into the spinal cord. And here you may ask, so can we just treat the spinal cord injury patients with NGF and get axons regeneration going? So why do we even need to know about this complicated intracellular regulation of the axon growth? The answer is simple. So because the majority of those neurons in the central nervous system including all those whose axons run into the spinal cord, do not express this NGF receptor and therefore cannot respond to NGF stimuli with axon growth. However, all those neurons do have this signaling molecule inside them, including the BRAF. So we then tested whether activation of the BRAF can trigger the growth of injured spinal cord axons in the cortical spinal tract. The cortical spinal tract, as just showed you, is a bundle of primary descending axons conducting motor control signals from the brain to the effector neurons residing in the spinal cord. And the spinal cord injury interrupt this connection. To see whether activation of the BRAF can enable axon growth in the injured spinal cord, we subject mice and anesthesia to a spinal cord injury. And mice subject to this surgery are not severely paralyzed and can still feed themselves. As you have seen in Kahat's drawing, the nerve cell bodies of the cortical spinal tract projection neurons here in green reside in the cortex. Here in this mice, we use the genetic method to express an active BRAF molecules in these cells. Here is what happened in the mouse spinal cord after 6 weeks after the injury. The site of injury here is marked by the white arrows, axons in green. And as expected, in the control mouse, no axons grow into and beyond the lesion site. And this is consistent with what we know from the spinal cord injury patients. But in the mouse where cortical spinal neurons express active BRAF protein, we see substantial numbers of axons growing into and beyond the lesion site. And here is a high magnification. So just as I mentioned before, axons function roughly like electrical wires. So we tested for electrical conductivity after spinal cord injury in mice. So we artificially stimulate the neurons in the motor cortex and recorded electrical signals from the leg muscle. And this is a set of recording from the intact mouse without spinal cord injury. You see how these signals look under normal circumstances. In control mouse, 6 weeks after spinal cord injury, no signal can be detected, which means no information can be sent from the brain to the muscle. So in a mouse expression activated BRAF molecule, and strong signals can be detected in the muscle 6 weeks post-injury. And here's the quantification of peak amplitude and the mean onset latencies. The white bars are from intact mice without injury, and the black bars are from the injured BRAF mice. And this tiny gray bar is the injured control mice. And the activation of the BRAF did not achieve a complete restoration, but a very significant improvement over the control. And in spinal cord injury patients, this level of cortex to muscle signaling could make a real difference. And I will come back to this at the end of my talk. So now we know that activation of the BRAF signaling in cortical spinal neurons triggers axon regeneration in the injured spinal cord. Our next step is to apply these findings to the clinic. And of course, we cannot just go and genetically engineer spinal cord injury patients to express activated BRAF in their cortical spinal neurons. So how can we activate BRAF signaling in patients? So we need an applicable, sorry, I heard something. So we need an applicable low-risk way to activate growth signaling in cortical spinal neurons. And the previous study has shown that high-frequency electrical stimulation can activate BRAF in neurons. there are high magnification images of nerve fibers in a petri dish. The inactive BRAF protein in this experiment emit a green fluorescence. Upon electrical stimulation, the RAF protein is activated and the color changes to red. So we reason that high-frequency electrical stimulation may also activate RAF signaling in neurons in the brain. And repetitive transcranial magnetic stimulation, abbreviated RTMS, is a technique to administer high-frequency electrical stimulation to the brain tissue underneath the skull. And RTMS is an FDA-approved therapeutic treatment for severe depression and migraines, as well as pain. This is an illustration of the principle of RTMS. So electrical current sent through a wire coil, which generates a pulsing magnetic field according to the laws of electromagnetic induction. The magnetic field penetrates the skull non-invasively and induce a pulsed electrical field in the brain tissue. Here, this cartoon showed the RTMS coil positioned over the mouse head. And our collaborator at the Harvard Medical School calculated the electromagnetic field generated by our RTMS stimulation in mouse brain. And this model suggests that we expose the cortical spinal projection neurons, which are located here in this small red area, to an electrical field intensity of 40 to 80 volt per meter. And this is an intensity that has been shown to activate cortical nerve cells in non-human primates. And this high frequency RTMS, 40 to 80 volt per meter, promote axon regeneration. So again, we test this in mice. So we tested the efficacy of RTMS in promoting CST axon regeneration using this timeline. So the RTMS was conducted daily for 6 weeks, as indicated here by this red bars. In mice without RTMS, there is literally no cortical spinal axon regeneration. And the high frequency RTMS treatment resulted in axon growth beyond the lesion site, and similar to that which we saw in mice with BRAF activation before. And this is the same image with higher magnification, as you can see here. So moreover, we find that high-frequency RTMS powerfully increase axon sprouting from the intact neurons. So most spinal cord injuries are incomplete, which means that not all axons at the injured site are damaged. Some axons here, half of those axons remain intact and may grow new branches into the areas that used to be innervated by the saved axons. You can see here. This phenomenon is called axon sprouting and could be beneficial to patch up damaged circuitry and compensate lost neurological function after a partial spinal cord injury. So again, due to this very low growth ability of mature central nervous system neurons in the central nervous system, axon sprouting is very limited in the wild-type mouse. As you can see here, almost no sprouting. So in this RTMS-treated mouse, however, we saw a denser axons in the denervated area, so indicating an extensive axon sprouting, so which may be beneficial for the function recovery. So having showed that high-frequency RTMS can elicit cortical axon regeneration and sprouting in the spinal cord injury mice, so we have started a phase 1 clinical trial to assess the feasibility and the safety of high-frequency RTMS. So the patient will be treated with high-frequency RTMS for 3 weeks using parameters equivalent to those we have tested in mice. And we will monitor the patient closely during and after the treatment. So we will pay special attention to possible adverse effects such as dizziness, pain, and spasticity, and also record electrical conductivity and measure patient's hand function after RTMS with standard functional assessments. So we are collaborating with a group of clinical specialists at the Kessler Rehabilitation Institute in New Jersey. So we have just completed testing with able-bodied volunteers as shown here. And so far, so good. And currently, we are recruiting subacute, that means 2 to 6 weeks after injury, spinal cord injury patients for this safety trial. So nowadays, patients enter the rehab program so their brains can learn how to repurpose neural connections that were spared by the injury to compensate for some lost functionality. And this process where spared connections remodeled to make some new connections or learn new tasks is called neuroplasticity. But in real life, plasticity is very limited, and the spinal cord injury patients, even with intensive rehab, typically do not recover to the degree that they need in terms of useful functionality. It is our hope that by enabling axon growth and regeneration in the injured spinal cord with new treatment strategies, such as high-frequency RTMS, we supply more material for the rehab-guided plasticity process to act on and result in greater and more functionally meaningful recovery. And this image shows a rehabilitation training session conducted by my colleagues here at the Berkeley Institute. And they are developing novel rehabilitation strategies involving robotics and other cutting-edge techniques for patients with stroke and other neurological conditions, and some of which may also be applied to spinal cord injury patients. And spinal cord injury has been an exceedingly difficult condition to treat. But directed by a deeper understanding of the mechanisms of axon growth and advanced rehabilitation, so we can develop new therapeutic strategies to facilitate functional recovery after spinal cord injury and other traumatic nerve system injuries, where rebuilding of physical neural connections is needed. And I stop here and would be happy to hear your comments and suggestions. And thank you for your attention. And thank the SCRP for the support.
Thank you so much, Dr. Zhang. That was really, really a fantastic talk. Thank you so much. And I wanted to just build on something that you said. So obviously there's a very big interest in moving these discoveries from animal models to human patients. So can you tell me, what is the biggest obstacle in doing that? What is the thing you've experienced the most?
I personally don't have a lot of experience with spinal injury patients, but what I know is the recovery of the spinal injury, or in general, the traumatic brain injuries in general, is very difficult to cure. I think one of the main issue is the low ability of the axon growth in those neurons. So after injury, the axons cannot regrow and they cannot make the new connections. This is one of the measures. The second is, as I mentioned, so there are inhibitory molecules which block this growth. Okay, this makes things even worse. And so there are many techniques now developed to try to target those questions, but the things we don't know. So what happened in the neurons? So those techniques sometimes works well, sometimes not. So cannot be applied to the human patient with expected outcomes. Okay, the outcomes are very differently. Just also depend on whether this injury is complete or also incomplete. And so I think when we understand the mechanism of axon growth or sprouting, so we can develop targeted strategies to address these issues. And the interaction between the basic research and the human study and also the rehab, I think that's the combination will provide the optimal platform for the development of the new therapy. Many, not my lab here at Berkeley, it's also at Berkeley, there are many other labs you have heard from Dr. Hollis, from Dr. Friedel before. Many labs are working on this big questions, and we hope so with this joint effort will take us to the new therapies.
Wonderful. And you were explaining prior to, I think, a lot of people joining today that another big obstacle is patient recruitment for clinical trials. And just to reach out to any of those who are participating in this particular webinar or listening to the recording later on, we did in the chat window put the link to the clinical trial registry at Berk Neurological Institute. So hopefully, Dr. Zhang, we can help recruit some of those patients for your studies. So we do have another question here from Christine. She's asking, has there been any evidence that shows that infrared light therapy may be helpful in spinal cord injury?
Infrared therapy. So I don't know where you are going to place this infrared in the brain or in the spinal cord. So I was not familiar with this technique.
Okay.
I have a question. John, maybe you could talk about sort of what's been learned from molecules that promote cancer in terms of how those might be relevant to some of the studies you've done in trying to reactivate axon growth in adults.
Okay, that's an excellent question. So, so interestingly, so the BRAF that I just mentioned, you heard in my talk, is a proto-oncogene, so which is activated in cancer cells. Okay, so interestingly, so my colleague Jian Zhong's lab at Harvard Children's Hospital, they find deletion of the P10. There's another oncogene which also causes cancer in non-neural cells, can promote axon regeneration. So why those pathways which promote cancer development can promote axon growth in neurons? As we know, so neurons, they cannot differentiate and they cannot develop to cancer cells, but those pathways can promote axon growth. So we don't actually know that yet, but so we are working on this signaling mechanisms. We try to identify molecules which is downstream, also activated by the BRAF, to see which of those molecules are involved in promoting axon growth. So this is an ongoing study, so also supported by the SCRP. So, but in general, we think, so when we activate this pathway, just like using this RTMS, transient activation of those pathways, we may get the beneficial effect, and then we just avoid those cancer development. So, and also find the conditions which we can maximize our effect on the promoting on axon growth, but avoid this detrimental effect. And those are just the things that we are working on. And this is very good question. So this phenomenon, so we are still puzzling and trying to figure that out. Yeah.
Thank you so much, Dr. Zhang. I think, Nancy, do you have a question?
Yeah, I do. Maybe two. The first one is, in the study that you're doing, are you only using acute patients, or are you using people in the study who are chronic, had their history for a number of years?
Yeah. Okay. So of course we want to apply this treatment to both acute and chronic patients. So in the first stage right now, so we want to test this in subacute spinal cord injury patients. There are several reasons why we want to do that, because those they told me is those subacute patients, they come to the therapies regularly, and then it's easy to recruit those patients. That's the first, and then so they will test all the functional movements and electrophysiological measurements, and this can be done easily. Okay, and since we just use a very small group of patients, so we want to test our RTMS in those patients first. But if it turns out this is applicable for the patients, so of course we will expand this to the chronic patients. This can be done very quickly. So, and then we will test the functional outcomes, right? That's not just a safety study. Then we will test the functional outcomes. Since we know this in those chronic spinal cord injury patients, so rehab is already done, and so they cannot gain much more recovery after that. So we want to test whether activation of this BRAF using this new protocol, whether we can improve this the functioning outcomes.
Did you see any change in the people who you did this treatment on, who were subacute? I assume that means like not 6 months after, but a couple of months after their injury. Did you see any, movement or any physical change simply by doing the phase 1 trial?
We are measuring all those parameters in those phase 0 trial. So, but we now focus on those detrimental outcomes. Okay, we want to just make sure this treatment is safe for now. Okay, but we will collect all the data from the patients and to make a judgment. Since we did that in the mice, so we can also go back if we want to make any adjustment, and we will go back to test this in the mice. But at the end is we want to just make sure this treatment is safe. And since this is RTMS is FDA approved technique, so we don't have a lot of concerns, but still we want to see whether the treatment, also especially those long-lasting treatment, will have any effects. We just want to know that, and before we move on to the next step.
Thank you so much. And for those of you who do have questions, if you could please put them in the chat, because it does help the other participants to think about some of the questions that they have for Dr. Zhang as well. So on to the next question. It's from Fran, who wants to thank you for your in-depth presentation. And she's asking, are you currently exploring any clinical trials for patients who have complete spinal cord injuries? Also, are there any age limitations for your current participants?
First, so we try to recruit patients with different degrees of the spinal injury. We don't just exclude just a complete spinal injury or the incomplete spinal injury. We try to recruit both of them. So even though in a small cohort of the participants, okay. And so regarding this the age limitation, so we discussed about that. So we don't want to recruit patients, just like say less than 10 years old, just those young patients. Since the growth ability of the neurons at very young ages, they are different as those neurons in the adult patients. So we just want to avoid that for the first phase 0 study. So of course we will in our next step when we include those patients. Also, we want the things that we don't want, since the brain were still developing at a very young age, and we don't want to subject those patients to this RTMS, which will induce axon growth also in the brain, right? So just remember, this is not just to this very specific spinal motor neurons, but also other neurons, and which may cause some unexpected outcomes. So we right now, so we want to just exclude those young patients.
Thank you. And I think it might be helpful too. So you just described your phase 0 trial. Can you give our participants today an understanding of what the timeline looks like for this to actually be part of practice in medicine? Like, how many years does that take, or what are your thoughts on that? Okay,
so that depends on lots of factors. Also, even the pandemic now. Okay, so the Cancer Institute, also Berg, we have to close a large part of the capacity just to meet this requirement, and we just now reopened slowly, also in New Jersey, and this is something we don't expect, we cannot plan, and also depend on the funding, since those human studies are very expensive, and especially those spinal cord injury patients, the transportation costs a lot, and we critically depend on the funding. Okay, if without this funding, so we just cannot, literally cannot conduct this study, and this is I think the most important part. We just want to make sure so we can continue the study to get the results what we need for the next step. And if we can, those can be done within let's say 1 or 2 months. So for the treatment, I said 3 weeks for the treatment, and then we wait another 6 weeks for the follow-up to see whether there is some long-lasting effect. And then if everything are positive, we can submit our IRB application, and then move on to the next level, and to test this functional efficacy of this RTMS in functional recovery. So this can be done again. So maybe in time frame of 1 year or half year, it can be done. And so just I just want to mention, okay, if the pandemic continues and the new variants come up, then we delay this. And also the funding, if New York State just cancel the funding, which we don't hope, that will also delay this study significantly. Yeah.
Thank you. And we have a question from Kelly, and she's asking, I think what she's asking is, how soon after an injury could somebody be included in the study? So what's the minimum of time? Okay, we say so 2 weeks to 4 weeks, but we just discussed this, maybe 1 week after the injury. So this is also depend on the clinical evaluation. The doctors may decide whether this is the treatment is safe to the patient. Since spinal cord injury is not a small injury, this is huge, and will have impact on many body functions. The physicians need to just stabilize the condition, and then give us a green signal, say, okay, this patient can participate in this study. And we say so from 1 week to 4 weeks. So that's the time frame we have now. Okay, and then the second part of that question, is there any risks to the patients?
Again, so very, very important question. So we monitor the patients every day, every day during and after the treatment. So this is 3 weeks and 6 weeks thereafter. So, and even beyond that. So we will contact the patient every day, daily, and to get their feedback. And if there is anything, any detrimental effect, may not be the consequence of the RTMS treatment. Maybe it's just since you have this severe surgery, injury, right? And there's lots of consequences, the detrimental consequences. So, but we will document that and evaluate that, since they are very experienced, those people in the Kessler. So they have, I think, the largest or second largest population of spinal cord injury patients there. Christoph Reeves was treated there. And they have a very experienced team. They can evaluate that. And then we can say, okay, we stop the trial, and or we can modify the parameters. So the good things, so we can also test that. If they find something, we can test that in our mouse models. So this is easy and don't not cost so much. And and that's I think the beauty between this translation study. So we can going back and forth. The information can go both sides, and we can learn from each other.
And then we have a question from Robert, and he's asking if fluid in the spinal cord, which I hope I'm pronouncing this correctly, syrinx, if fluid in the spinal cord can cause any effect with your leg muscles.
The fluid in the spinal cord will cause any effect in the muscle. So as I showed before, the muscle is connected to the spinal motor neurons, right, in the spinal cord, and the motor neurons in the spinal cord is connected with this cortical spinal neurons in the brain. So this signal comes from the brain to the spinal cord and then to the muscle. Okay, when you when the neurons in the brain send a signal, and it go to the spinal cord and then control the movement of the muscle and the position of the muscle when you close your eye. So you know where your arms, legs are, right? And the signal, this is a purposive pathway. The signal go from your muscle back to the spinal cord and then to your brain. And after the spinal cord injury, of course, if it's complete injury, so this connection are completely gone. So then you don't know where your arms are, and you don't know how to move your arms, right? And so if there is a abnormal conditions in the spinal cord which damage the axons, then you will lose the control to the spine, to the muscle. So then we have some they can move autonomously, but you cannot control those movements. That's the issue. Okay, it's not we want just those arms move randomly. So you can use the electrical stimulation to move those arms. But the thing is that you want to have a controlled movement, so to fulfill some specific task, right?
Thank you. And then, so you showed us a great schematic of, and you showed patients who actually were getting TMS, and it looked like a device that went on the head. And obviously, we're in clinical trials, so that needs to be done in a controlled, environment. And it's done usually in a place that's not inside the home. Do you foresee eventually that TMS, based on the results of all of these studies, would it be some sort of wearable device in the future that these treatments can be done at home?
So it's a very interesting question. So I hope so. Okay, I hope so. But at this stage, I cannot predict how this can be done at home, so by the patient itself. The things that you saw this, the pictures. Let me see whether I can go back. So this picture, right? So this is a coordination system, as they call it, navigation system. Okay, and this coil is you can see the position very precise placed to this motor cortex called the M1 area, and the intensity of this coil is precisely controlled. Okay, so you don't want to over excite it, and you don't want to excite the areas which are not related to the spinal cord projection axons. And this is the system, okay? And I don't think right now, as it is, you can set up this in your basement. I don't think it's possible right now. But yeah, in several years, so maybe I don't want to say it's not possible, but right now, as it is right now, so I don't think it's feasible as it is. But if we can show the treatment has very strong effect, and if the market has this requirement, so yeah, people may come up with some ideas. Yeah, there are many engineers and talented engineers, so they may be able to resolve the problem.
So we'll be listening intently and watching your studies to see how everything progresses. And when you were showing the studies in the mice when there was an injury and that we saw axons growing past the injury site, did any of those animals recover full function?
No. This is another very important topic. So I just try to address that in my last slide. So I believe the axon growth and the reconnection is just the first step for the function recovery. So we need also very professional, also targeted rehab program. I don't know how to do that in mice, but my colleagues here at Berkeley, so you heard a lot, so they know how to do it. And if we can provide some of the material, as I said, and they may quickly take advantage of that and to test whether those new connections can translate to function recovery. So that is my hope. Okay, it's not just the function, the new connection, but also the brain and the neurons in the spinal cord need to learn how to talk to each other, since this is not the same connection. Okay, as you can see also from the MEP, this is the form of the MEP. They are not exactly the same, and the brain need to learn how to deal with that. And that is I think this is I didn't mention, since we don't have this expertise, but we know who we can talk to. Okay.
Very good. All right, we have about 5 minutes left. I've done a last call for questions. And Dr. Zhang, is there anything else really important? You have this incredible audience today. Is there anything really important or part of your message that you'd like to deliver today?
Okay, so we just talked about. So if you see the background of here, this is the Alps in Switzerland. Okay, and this is the ski resort, and very famous ski resort. And so when I went there, and I saw the helicopters almost every day. So they are flying over my head. And why they are there? Because they are transporting those spinal cord injury skiers. So since there are lots of accidents there, so almost every day. And those people, but you cannot stop them to go there to ski. And I think this this is the problem we will have, spinal cord injury we will have. And in addition to those fall, and there's a short one. And so if we can develop a way, so in whatever aspects, okay, to improve the quality of life of those spinal cord injury patients, I think so it worth all the time and money, okay. And that's the thing. So we all not people in my lab, but also at Berkeley, we all working on. So I think this is also one thing we need to understand. So the nerve system is the most important, precise machinery in our body to control everything. Okay, and loss of even a small part of the functionality of the brain of the nerve system will cause tremendous damage, and we need to, we just need to find a way to recover, to facilitate the recovery, and also the same principle I think we can also apply to the other traumatic nerve system injuries such as stroke. Okay, and this is I think will become also is a central question of our research.
Thank you so much. And we're just about out of time. I just wanted to thank everyone who joined us today for giving us the last 60 minutes of their time. And also, Dr. Zhang, thank you so much for your time and your dedication to educating the public. We really appreciate it today. And just to repeat that we do have the SCRP campaign going on. So again, we put the link up in the chat window. So if you wouldn't mind taking a few moments and just helping us to let the legislators know how important this funding is to spinal cord injury research. Also, this webinar is being recorded, and we will be emailing the link to all of the folks in our database, as well as putting it on our website. So again, we want you all to stay safe, stay well, stay informed, and we want to wish everybody a great weekend. Thank you again, Dr. Zhang.
Thank you very much for your attention. And also, just the last word. So we were very appreciate the support of the SCRP, the New York State Spinal Cord Injury Board. Okay, thank you for your support, Nancy.
Thank you very much, everyone. Have a great weekend. Bye-bye.
Thank you.